During the acute phase or the initial phase, those patients need to be hospitalized. The way that we've done it, we actually are able to do the chemotherapy outpatient, and then we admit the patients into the hospital for around 3 to 4 weeks, where they will need regular blood transfusions. They will need monitoring for complications, namely infection. Those patients go on prophylactic antibiotics to prevent infection during that course. Once the counts recover, then they are going to be discharged to the outpatient setting. In the outpatient setting, obviously, we assess the response. We assess that those patients are in remission. We assess any potential toxicity for those patients that's persisting. And then we decide on the next step of treatment, which is what we call the consolidation. So those patients will get further chemotherapy. Sometimes they'll get 1 or 2 more rounds of the CPX-351. Those patients are going to proceed to transplant, may proceed to transplant immediately. Or if there is a delay, they could get further consolidation, 1 or 2 cycles, and then go to transplant. So when this patient presented, his white count was high, his creatinine is high. One would do things like hydration, check uric acid. If it's elevated, prescribe medications to lower the uric acid. And then during the course of the treatment, patients will be on prophylactic medications to prevent infection, whether it's viral, bacterial, or fungal infection. They will need blood transfusion supportive care, platelet and red blood cell transfusion. They do get, baseline cardiac evaluation. Some of them may have arrhythmias during course of treatment, whether it's the 3+7 or the CPX. So one would monitor for that. The mainstay of supportive care management is in terms of infection prophylaxis, blood products support. Some of the patients will get what we call mucositis, inflammation of the gut, diarrhea. They will need some supportive treatment for that as well. In this patient, yes, the patient has therapy-related AML. It's considered high risk, so we will evaluate this patient for possibility of allogeneic stem cell transplant. It will depend on how how he tolerated the intensive chemotherapy, his organ function testing, availability of a donor. But ultimately, if this patient can go to allogeneic stem cell transplant, that's probably the most potentially curative option for this patient. If patient is going to transplant, sometimes the timing of the transplant may depend on many things. On average, it takes 3 to 4 months to get to transplant. So sometimes we will do 1 consolidation cycle of chemotherapy before transplant. Patients that are not proceeding to transplant, definitely we plan to do consolidation. In the CPX-351 study, patients were offered consolidation with 1 or 2 cycles of the CPX-351.